talking about exploring the nature and treatment of chronic pain in the Australian aged care setting. Being a dementia consultant and working in the aged care sector for 35 years, my focus has been on changing the world and the journey of people living with dementia and showing people that there is a better way out there that doesn't require all of those negative stereotypical viewpoints that judge people and restrict them from living the life. It's based on a purely cognitive viewpoint. And so really, we're doing it the wrong way around here. We need to be seeing life through the eyes of the people we care for, and it's the only way to individualise care in the true sense of the word and provide the care that every individual as a specific person in their own right and a product of their own life transitions deserves. So this was a nice little arm for me to go out into with all of my current clinical research in the field of dementia, but also in the aged care setting. Pain is a massive area of concern in aged care around the world, not just in the Australian aged care setting, but this is where we're looking at, because at the moment for Australians, it's Australian research done by Australians, for Australians to enter into the medicinal cannabis field. So we decided that we would start looking at this. Chris Alderman is the Clinical Director of Ward Medication Management. He is a clinical pharmacologist who has worked in the aged care sector for just about as long as I have. But between the two of us, we've got about 65 years in the aged care sector to hold us in good stead to get something like this off the ground. Then we have the rest of the ward medication management team, who have enabled us to get to the stage where we have to do the UNPAC study, which is understanding the pain in aged care. Potent opioid analgesics are widely prescribed within the aged care sector, but they are associated with the highest degree of harm. What are we doing? We are overprescribing and giving people drugs of such a high quantity that not only is it destroying their quality of life, in 73% of cases it's not even managing their pain. So associated with that are all the adjuvant medications that you give people to manage all the side effects that come along and the adverse effects that come along with using gross amount of opioids on a daily basis. So what we're actually doing is not managing the pain of the majority of our older population, and we're destroying their quality of life by the cascading effects of polypharmacy and the huge amount of other drugs that we're doing to compound the effects of the opioids, which aren't doing anything anyway. Doesn't make sense, does it? So this is the abstract. I'm not going to read through it. I've basically explained what we're looking at. We're disrupting the opioid trade. We're stopping polypharmacy. We're improving the quality of life of the people that we're caring for in aged care by giving them an alternative that we potentially believe very strongly is going to avoid all of these destructive elements that I've just briefly described and come up with an alternative that meets the needs of each person specifically in regards to their chronic pain and maximise their quality of life, provide them with the time of their life, the golden years that they all deserve at this time of their life, to continue the journey that is the last chapter of this life experience. They don't deserve anything less. And in this day and age, with medical technology, we would be condoning continuing the use of something that we see as non-effective, which is in fact neglect and abuse. So what we need to do is come up with an alternative and make sure that everybody realises that in this day and age there is no excuse for anyone to suffer chronic pain. It is a critical and rapidly escalating problem. As we know, the aged care sector is rapidly growing with the onsurge of the baby boomers. We're going to have an 80% increase in their population over the age of 65 within the next few years. I'm a baby boomer, so I'm on the cusp there. So anyone over my age in this room is considered a baby boomer. It's been recognised as a predominant prevalent human encounter, so no person is excluded from pain at some stage of their life. Some of us can't actually perceive what it's like to be in the level of pain that I'm talking about. So what we need to do is once again see it through the eyes of the people that we're caring for, understand the repercussions of living like that. It is considered one of the most poorly managed conditions because of the ineffective traditional drug regimes that they've been using ever since I started in the field, which is 35 years ago. Now, after 35 years of watching people in chronic pain and feeling that pain, not being able to do anything about it, it's about time someone made a stand. It should be recognised that access to effective pain relief is a basic human right. It's all about quality of care. No one has the right to say, no, you can't have that, even though it works, because of all the laws surrounding something. For goodness sake, the opioids are also a plant. Now, if they can get away with that, they can get away with medicinal cannabinoids. Thus, we need to look at the alternative. This is we started collecting all the data, which is the basis of our clinical trials. So we have a population in Australia of 25 million people, with 300,000 currently in residential aged care facilities. That is quite a high percentage, but it doesn't take into account the number of people also in the community that are being cared for at home who are still living in chronic pain. The nature of aged care has changed. People are going into aged care now with a higher acuity of care. They're not going in at the lower stages of care anymore because there's not enough places to go around and not enough beds. So people are being cared for at home for longer by their families and the informal caregiver, which is a whole nother tangent in regards to care strain and all of the other complications that occur because of that. Medication use is extensive. So when you're in aged care and you're on all of this polypharmacy and your opioid regimes, you actually are potentially causing a higher ratio of drug-related harm. Despite this, many have suboptimal control. Pain arises from various sources. We have our acute pain, our pain in the context of life-limiting illness, which we heard about today in regards to oncology and palliation and the areas in terminal end-stage life. We have our chronic, somatic and visceral pain and our neuropathic pain, which is our nerve pain. Many traditional approaches use currently non-pharmacological approaches. This is all well and good if it's helping to manage the pain, but if you've still got that element of pain, you need to deal with that first. Then you can massage, then you can give other therapies that are wonderful and assist with anxiety and pain-related symptoms. However, we need to actually look at the core first and understand the levels of pain that people are suffering. We cannot allow them to suffer ongoing because what it does is it destroys all quality of life. The simple analgesia is being used and overused. Shocking. As well as the intermediate potency analgesics, our potent opioids, and like I said, all the adjuvant agents that you tack on the end of using an opioid, you've got 10 or 15 more medications with all their own set of adverse effects that are going to be then basically creating a problem that is just a spiral downwards. It's not really helping anyone. I think I said this earlier, that Einstein's definition of insanity is doing the same thing over and over and over again, expecting a different result. Is this not what we're doing with the opioid trade? Are we not overusing, overprescribing, and giving way too many of opioids to people when we actually have statistics to prove that in 73% of these cases, it is not effectively meeting their needs in any way. It is not managing their pain. Why is it that we just keep on doing it? So we do need to look at another alternative. Chronic pain is a massive burden. Nobody wants to live with that for the rest of their life, and no one should have to. It is that overall suffering, that never-ending, debilitating sense of misery and despair that people live with when they have to live with pain of this nature. It comes from many different etiologies. There are lots of conditions where pain is a major symptom. I could tell you 10 million, so I'm not even going to go there. It's especially difficult, however, in the context of dementia, and this again is something that draws me into looking at pain, because if pain is mismanaged, people living with dementia will basically exhibit behavioural expression because their needs are not being met in the area of pain. People assume they don't have pain because they can't verbalise it. I don't know why they can't use their observational ability to see that someone's in pain, but a lot of people miss that. So if someone doesn't actually say it to you, they just assume that that person's not in pain. Or that people that have a cognitive deficit don't feel pain like we do. What a crock. It's an absolute lie, because people with dementia feel pain just as acutely as we do. They just basically communicate it differently, and if they're exhibiting behavioural expression, which I don't really like the term BPSD because it suggests that behaviour is totally linked to dementia, but every single person, cognitively aware or not, exhibits behavioural expression if they're not happy about something in their life. So I don't tend to use that. I use my own term, which is behavioural expression, which has been accepted, so that's fine. So we need to understand that this type of behaviour can come in aged care, especially in regards to dementia, and people trying to communicate to you that we're not meeting their needs. Come on, guys, I'm in pain. That's why I'm resistive. That's why I don't want to do anything today. That's why I don't want to eat, because I feel like crap. So basically, we need to look at that and we need to manage it better to avoid people having to express through their behaviour that they're in pain. And then there's another extension that occurs with that, is that when people are in huge amounts of pain, they become acutely delirious. So it exacerbates everything that we're talking about and destroys quality of life even further. And we're creating it. We are the triggers here. Chronic pain, this has all been spoken about today, so I might actually run through it pretty quickly because I'm going to run out of time. Oh, no, I'm just going to keep talking. Who stipulates the defined daily dose for all pharmaceutical drugs, 75 for oxycodone, 100 for morph, 300 for tramadol. In 2014, it showed that oxycodone was above the DDD increased rate of 9% or 9.1% already in 2015. Year-on-year prescribing rates for morph and tramadol have remained stable. In fact, especially tramadol has gone down because it makes people feel really sick most of the time. Prescribing of oxycodone has increased rapidly, even more. 738 cases in 2014 in Australia, 1,512, 1,016 for the first 5 months of 2016. So what we're seeing, as discussed a lot today, is an increase in the use of drugs that aren't actually effectively meeting the needs of the people that we're caring for. The downsides of opiates, look, I've talked about it already, haven't I? Nausea, vomiting, constipation, that's a killer. Has anyone ever been really badly constipated? The pain that causes, especially in an elderly, vulnerable person, can actually be excruciating. Sedation and respiratory depression, tachyphylaxis tolerance. I mean, really? What's the biggest one? Fatality, death. Overuse of opioids, overprescribing and addiction issues can lead to death. Don't really say that about medicinal cannabis, do we? It's a much safer option. What we did was, to do this unpack study, we looked at medication reviews in the aged care sector. Ward Medication Management, who we're affiliated with, are clinical pharmacologists, and what they do is they go out to residential aged care facilities and they do quarterly reviews on every single person in those facilities, and they make recommendations. They reduce polypharmacy. They look at the drug interactions of everything that's been prescribed by a GP. So they work in collaboration with everyone to try and fix this problem. So these are the guys that we're working with, and they've looked at the basic data profile of all of those reviews, and their database has given us the results that we need to now go down in the clinical trial phase. That's pretty obvious. I'm not even going to go there. Or there, because I've spoken about all our adjuvants. So wrapping it up, widespread use of analgesic and adjuvant medications for the management in the aged care cohort in Australia needs an effective alternative. Hence why we're going down this trail and why we feel very passionate about making a difference in an area that is so highly needed. Australia is very interested in doing the right thing and looking after its population. We just need to convince them by giving them the clinical research and the evidence-based trials and the data that supports why we're doing it and how, we've identified the problem, we're giving them the solution. Listen to us. So we're looking at the very optimistic and positive approach of medicinal cannabis. And we are, as we've discussed with lots of people today, there's lots of regulatory issues. There's going to have it happen in every country. But if you know what those regulatory issues are, you know how to work with due diligence, you know proper procedure, no matter what you do, if you follow that pathway in this field, the outcome's going to remain the same. So what we need to do is just focus on our outcome, do what we need to do to get where we need to get, and make this happen. So our findings illustrated the scope of use of medicinal cannabis through our data collection and working in the field for as long as we have, and finding the beneficial alternative. My motto is be the change you want to see in the world. If you want to see change happen, do it yourself. So I have that tattooed on my back to always remind me that no matter what, if I have the courage of my own convictions, I can make change happen. I've done it before and I can do it again. Very smart man, Gandhi. Look at those faces, no pain there. Thank you.